Hi, I'm Jeremy Reed. Thanks for watching. Today I'd like to show you my condensed and high yield knee exam that I use every day in my clinical practice. This is not the knee exam that will help you pass LMCC or one of your med school OSCEs. This is what I've cut things down to after about 10 years of doing this on my own. So the first thing is to have the patient laying flat on the bed, head resting on the pillow. What that does is it ensures that their abs aren't contracted, because as soon as they look up and try and help you, abs will tighten up, quads will tighten up, it'll limit your exam. Make sure the other knee is down flat. A lot of people will try and sit there with it flexed up, which again limits your exam somewhat. Once that's all set up, start with simple range of motion. Check flexion, extension, checking the degree of recurvatum compared to the opposite side. Evan's opposite side is not normal because he had a meniscectomy 9 days ago. After that, I start by testing the collateral ligaments with the knee in full extension, valgus to test medial, varus force to test the lateral side, and then the same thing with the knee at 20 degrees, valgus to test medial, varus to test lateral. There'll be some opening at 20 degrees, but it's only pathologic if it's different than the unaffected knee. Then we do the cruciates, bringing the knee down over the side of the bed. It's important to have the patient over to the side of the bed, and this is a perfect example of why having your exam bed pushed up against the wall sometimes limits what you can do. With the foot down between your legs, you can extend the knee over the side. This relaxes the quads and gives you a better exam. What you can also do is, if you find yourself having trouble getting the knee to move, you can change the degree of flexion that you're in, and that can sometimes give you a little better feel. You can bring the knee up onto the bed at this point and check for a posterior sag, which would be indicative of PCL injury. And then what you do is you look right down the tibial tubercles, and they should line up. If you find one is sagged back more than the other, like so, that's a pretty sure sign that something's wrong with the PCL. If you are concerned, you can do what I call the thumb test, which is simply you take your two thumbs and run them down either side of the patellar tendon. And if you can feel the tibial plateaus there and they stop your thumbs, that probably indicates that things are fine. If they simply glide right past, that indicates that the tibia is drifted posteriorly, usually because of a PCL injury. While they're up in this position, it's a great time to palpate their joint line, which in my opinion is probably the highest yield thing you can do. Simply find the bottom of the kneecap, make your way medially, poke around, watch the patient's face, looking for any pain or apprehension. Go laterally, again, looking for pain or apprehension. If they do report some pain, what I find is very helpful is asking them if that recreates the pain that they have. And if it does, that in combination with a good story usually eliminates the need for an MRI, and I can make a surgical decision based on just that. The last thing I do is finish off with a patella exam. Simply mobilize the patella, a bit of downward pressure, a bit of a grind, looking for any crepitus, and then lastly, checking for any apprehension with a laterally directed and medially directed force. And that's it. You can see in about a minute and a half, we've got all the information we need to make a clinical decision, a surgical decision, or to pass along to the specialist that you're referring to. Thanks for watching.